welcome to Your Health, Your Choice. I am Dr. Roopnarine. And on tonight's program, we'll be discussing rheumatoid arthritis. With me in studio tonight to provide his expert opinion on the topic is Dr. Haramnauth Dyaanand. Dr. Dyaanand is a consultant rheumatologist, and Dr. Dyaanand is attached to his own specialist rheumatology center at Dumfries Road in Laramie. As usual tonight, our number should come up at the bottom of your screens, and we will do our very best to get to your questions in the final segment of the program. So, let's get the program started. Let's talk rheumatology, and let's say hello to Dr. Dyaanand. Hi, Doc.
Hi.
Thanks for coming on the program. Dr. Dyaanand, just to really get the show started and kicking off, in my opinion, I seem like rheumatoid arthritis is a very common problem in Trinidad. So a lot of the patients, everybody in the society, everyone talks about rheumatoid arthritis, and I tend to think that they're talking about rheumatoid arthritis. Yeah. So if you could just start us off in the discussion, if you could just tell us exactly what is rheumatoid arthritis, because I suspect a lot of people might be misinterpreting what it is. And if you could tell us exactly what is rheumatoid arthritis and exactly how big a problem is it in Trinidad and Tobago, how common is the problem? So,
sure. Good night, everyone, and thank you very much for the question.
Right.
So, rheumatoid arthritis, to put it very simply, is actually a condition in which you have inflammation in joints. So, actually, the word arthritis has Greek origins, and it stands for joint and inflammation. So, rheumatoid arthritis is just a specific condition which could cause joint, because you have quite a joint pain, swelling, and stiffness.
Right.
It's a chronic condition.
Right.
And if it causes inflammation in the joint, most of these patients present with joint pain, they present with joint swelling, they present with joint stiffness, and a lot of disability. Right. And it is a chronic condition, just like you would have like diabetes, hypertension, and all of those other conditions.
And how common is it in Trinidad and Tobago?
Right. So in Trinidad, there has not been any official nationwide study for rheumatoid arthritis. Right. But I myself have done some work at the hospital in San Fernando, and I've had quite a lot of patients from private also. So it's actually a big problem.
Yes.
So there's lots of patients who would suffer from it. Right. We probably have anywhere between 2 or 3% of the population that could be suffering from rheumatoid arthritis. Right. And we see all varieties of it. So to be honest with you, it is actually a significant problem in our country.
Okay. Okay. And what is the burden of rheumatoid arthritis worldwide? Is it that we have more cases in Trinidad than in other countries, or?
So I don't think that I could clearly say that we have more cases in Trinidad, but we certainly have a lot. But the burden in the world, again, it varies from about 1 to 2 to 3% of the population, depending on where you are in any country. Right. And Trinidad is not too far off that. All right.
Is there any genetic predispositions, or is there any racial predisposition towards rheumatoid arthritis?
Right. So there is genetic predisposition, because it's quite common knowledge to everybody. It runs in families. Right. I myself have had families where aunts and nieces and parents, they all have rheumatoid. There is a definite genetic link. Right. But we do see it outside of genetic association also. Right. So you might have somebody who will present with rheumatoid who don't have any family member who had rheumatoid at all. Right. At any point in time. So they often ask the question, how come I get rheumatoid? Right. But there is a link.
Right. And Doc, so how do the patients present? How would you as a rheumatologist diagnose that somebody has rheumatoid arthritis? More than likely, some of our viewers at home are sitting down, they're getting joint pains, and they're saying, look, I have rheumatoid arthritis. How would you approach a patient who's having joint pains? How would you diagnose the condition in someone?
Right, so the history itself is very important in diagnosing rheumatoid, because most patients, as you quite rightly say, we have a significant number of patients who have joint pain. Yes. But not every joint pain is going to be rheumatoid arthritis. Right. But rheumatoid arthritis belongs to a group of conditions called autoimmune disorders, and it's autoimmune inflammatory disorders. Right. And inflammatory disorders have a particular way they present. So they usually present quite suddenly. So a lot of people wake up and tell you, I was perfectly fine up until 3 weeks ago, I have sudden onset of pain. Okay. Then together with the sudden onset of pain, there is most of the time swelling of the joints, and most of the time stiffness. Now if you ask someone if they have stiffness in the joints, they will almost certainly say yes, but what you're looking at is the duration of stiffness in the morning.
Right.
So sudden onset, associated swelling, and stiffness that is usually lasts for more than 30 minutes tells you that there is inflammation in the joints. As compared to other conditions like osteoarthritis, which will actually be gradual onset, no significant early morning stiffness, 1 or 2 minutes, and you don't get any significant swelling with it. So it's a little clinical differentiation.
I think you have a slide with that as well.
With the joint.
Yeah, Josh, if you could pull up the slide on the symptoms and the diagnosis of rheumatoid arthritis.
Right, so there is a slide on the diagnosis.
Right, so what you're saying is that most of the patients will come in with a sudden onset of pain.
Yes.
Right, so this is the first diagnosis then.
Right, so the first thing that clues you in.
First thing that clues you in is that somebody will suddenly get pain in the joints.
Right.
Right, what age group is that?
Right, so it could actually vary from anywhere in their 20s, 30s, but most of the patients who I see who present is usually around 40s and 50s.
All right.
But you could get older people, you could get young.
Of course. So a typical onset, someone in 30s to 50s, sudden onset of joint pains, and the pain, the nature of the pain is that it lasts for greater than 30 minutes.
The stiffness.
Stiffness lasts for greater than 30 minutes.
The pain lasts forever until you do something about it. So they're usually quite debilitated.
All right. So I know you mentioned it, but I think I might have lost it. What is the difference between rheumatoid arthritis and osteoarthritis? If you could go back over that a little bit slower.
No
please.
problem.
Yeah.
So rheumatoid arthritis, being inflammatory, it has the characters, 3 key things.
Yes.
Acute onset, associated swelling, significant early morning stiffness.
Right.
And osteoarthritis, which is wear and tear arthritis, is more gradual onset, no significant swelling, and minimal early morning stiffness, like let us say 1 minute, 2 minutes, 5 minutes.
Right.
Now, so that's in terms of what the patient will complain.
Right.
But from our point of view,
so the patient comes into your office, and what happens next there?
Right, so what happens next, after you suspect the diagnosis based on the history, you would obviously examine, because you would want to confirm a clinical finding of a swollen, inflamed joint.
Right.
And then the next step after that is to do investigations.
Right.
So what I generally do is I choose, there's 2 lines of investigation. So you want to do routine general investigations for all patients, like a blood count, a kidney, a liver, just to make sure everything else is working good. But more specifically for diagnosis of rheumatoid arthritis, you need rheumatoid arthritis specific tests. And those are 2 that we have commonly available in Trinidad, which is your rheumatoid factor. And there's another test called an anti-CCP. So usually if I suspect any patient of having rheumatoid, I would want to do both the rheumatoid factor and the anti-CCP. But just to delve a little bit deeper, rheumatoid arthritis is just one group of condition which could cause inflammation in the joints. So there are some other conditions, in particular a group of condition called connective tissue disorders. The one that
you might go into a little bit later on.
So when I do the blood test in the beginning for rheumatoid, most of the times together with the rheumatoid specific test, I would do the other test at the same time.
Exactly.
So it helps make it clearer for me, are we going rheumatoid way or the other way?
Exactly. You don't want to help it just streamline the diagnosis.
Yes, streamline it from earlier.
And to remove the other conditions. So tell us a little bit about this test, because I think in the patient population, if you're a population, people who had these joint pains and see rheumatologists or going to the clinic and the hospital, there's a little bit of confusion or lack of understanding about what's going on with the blood test. For example, a lot of patients might come in to see me as a GP and say, look, I went to the clinic, the blood tests were negative, I do not have rheumatoid arthritis. And I would have to stop there and say, maybe we're misunderstanding what's happening here. Can you kind of clarify that for the patients at home? That's
Right. So what you're referring to is a very common situation we have. I probably saw it as recent as last week. So the first test, which is the rheumatoid factor test, that is the test that was traditionally done many, many years ago. So everybody knows about the rheumatoid test, which is the rheumatoid factor test. But only approximately 70% of the patients who have rheumatoid arthritis are going to have a positive rheumatoid factor. So what you could find is that what is going on with the next 30% of the population that have rheumatoid arthritis but a negative rheumatoid factor. And that is where the importance of additional tests like this anti-CCP test, which is another rheumatoid test, which is a little bit more specific, comes in. So you could have a negative rheumatoid factor test and your anti-CCP will be strongly positive and the diagnosis is rheumatoid arthritis.
And you can't have it the reverse.
And you can have it the reverse. Yes, you can have it the reverse also. So that's why I usually do both.
Okay. So that's how the patient presents with the pain and swelling, and those are the bloods they do, right? And then the diagnosis is made from there.
Yes.
All right, Doc. Before you go into treatments, right? I have to ask you one of the most important questions that most people that suffering from any condition who will tune into this program, they want to know. How are these guys going to help me cure my illness or get rid of my illness or help me get better? For example, when I was doing my rheumatology rotation 15 years ago as an intern, they had a class of drugs called disease-modifying drugs, which we will get into afterwards. And I remember the consultant looking at me. At that time, I was a fresh doctor, and he said, Robin, these drugs are working really well, and in your generation, you're going to be telling your patients that we're going to cure them from arthritis. And that was nearly 20 years ago. And are we really curing anybody from arthritis? Has a cure come along? Is there a cure for arthritis? Are we curing people from arthritis? And how far are we from a cure?
Right. So the term cure for arthritis needs a little clarification.
Yes.
So which is what I normally tell all patients. So when you have rheumatoid arthritis, you would always have rheumatoid arthritis. So we are never going to get rid of rheumatoid. So it is not like a chest infection. You take some antibiotics,
of course,
and it goes away, and you say, I don't have it at all.
So
what we use in terms of rheumatology, we use the term remission. So what we want to do is we want to put your rheumatoid arthritis into remission. And there's criteria that will tell us that the patient is in remission. And when we put your rheumatoid into remission, we want to maintain remission. And we could maintain remission in two ways. We could either maintain remission on medication, and we could maintain remission off medication. Now it's a gradual process. So you start the treatment early on, you shut the disease down, you bring it under control, you reach the stage of remission. If the patient stays in remission for a long enough time, then you said, well, okay, you're doing well, let us taper off.
And watch and
see. And if you are successful in tapering off medication, and all of this process takes a couple of years, then you could say, well, this patient is in remission, and they are in remission off medication. So we use the term remission in that say, and that is as close as you will get to as a cure.
All right. So my question, I know we haven't discussed the treatment yet, and we weren't going to get into that, but I really want to discuss this concept of remission, curing, which medical scientists maybe 20 years ago thought we were going to get to. So how many of our patients that come into us with rheumatoid arthritis are we able to put into remission with medication?
So at present, I would have to say that the percentage that go into remission is smaller than we would like. And there's a reason for that. And the reason for that is if you really want to put somebody into remission as soon as you could, you need to diagnose early. You need to institute the same disease-modifying drugs that you mentioned and we'll talk about later. You need to institute that treatment early, and then you allow those medications to get on top and shut the condition down. So we don't have a whole lot that we manage at for various reasons. Diagnosis not picked up early enough, maybe they didn't get the treatment they should have, get all sorts of things. But another aspect of it is patients staying on medication. Because we could do all what we want, but if you are not convinced that you need to stay on this, and you don't understand the long-term benefits, and you don't do it, then you will come off medication sooner than you should, and your condition will flare up. So overall, for many reasons, we don't have as much people going into this remission that we would like, but we do have a significant amount who do.
All right. So, Doc, a program like this is that we want the best outcome for our patients, right? We want to give the people out there, why we're doing this program is that because we want to give them information, to give them choices to get the best outcome. So, you're a consultant rheumatologist. We want to get the patients into remission. I understand what you just said there. I'm going to try and break it down into 3 key points, take-home points for the patients. The best way to get the patients into remission, or for people that get closest to a cure, is to get in early.
Early diagnosis,
Early diagnosis, and that means seeing a specialist doctor most of the times. Early treatment. And stepping up the treatment as necessary, and staying on the treatment. And that is a patient profile that we tend to get the best results with.
Definitely.
And patients that tend to, like Trinidadians with chronic diseases, sometimes we get fed up and we get tired, and we don't take the medications as much, and then those are the patients that are not going to get the remission. All right. So we discussed remission. Now, tell us what are the medications and the treatments that we go. So traditionally.
Right, so traditionally, in treating a patient, if we split the medications up a little bit for easy understanding.
Yes, please.
So there's two arms to treatment. One is called symptomatic treatment.
And Giles, I think we have a slide on the treatments as well.
We have a slide with some of this.
Yeah.
So you split it up into a symptomatic treatment and disease-modifying specific treatment. So symptomatic treatment is when we use things like steroids, the most common one being prednisolone. And when we use prednisolone, it acts very quickly. It settles the inflammation that we talked about, and the patient feels a lot better. But that should actually only be what we call bridging therapy. So steroid use and is well documented, and in an international guideline, it is there. Steroids to be used as bridging therapy. And what is it bridging? It is bridging you from the time that you make the diagnosis until you optimize the patient and until you put the patient on more specific medication. So most of the time, steroids is what we use.
All right. So you're saying that steroids is bridging medication, to put it in layman's terms.
Yes.
It's medication to get you comfortable until we could move on to the next step.
And then we prepare the patient as best as we could. And by prepare, what I mean is the same thing I referred to the blood count, the kidney, the liver. You want to make sure patients' other parameters are normal. The drug of choice for rheumatoid is methotrexate, which we'll talk about. You want to make sure the patient had a chest X-ray before we put them on the methotrexate. Then if there's anything else, patient vaccination is a big topic now. We want to optimize vaccination.
All right. So let's go back to the first step in medication, which is the bridging medication. Bridging medication, when the patient presents, is generally just prednisolone alone?
Well, we use
steroids,
steroids, whether prednisolone, dexamethasone, intramuscular form, steroids, and we also give I personally give anti-inflammatory painkillers in combination. So how I do it is an interesting way. I do steroids in the morning and after breakfast, and I will do an anti-inflammatory in the evening. But if the patient is doing well with the steroids alone, then they don't need to take the anti-inflammatory. They could supplement it with a little paracetamol, Panadol, like that.
All right. And in Trinidad, we use a lot of topicals and gels.
So there is some benefit to the topicals and gels, so you could use those things in combination, and that's fine. Just to ease the symptoms.
So those are the first line treatment. There's the easy symptoms while we do the other stuff. We get the investigations, we get your bloods, make sure your vaccines up in order, and then we step up the treatment. And this step up treatment is called the disease
modifying anti-rheumatic drugs.
So you can tell us about that.
So the disease modifying anti-rheumatic drugs, you have what are the drugs that the traditional drugs that we use, and those are drugs like methotrexate, sulfasalazine, hydroxychloroquine. There is a drug by the name of leflunomide. Everybody knows it commonly as Arava. So those are like the first line medication, and they are all tablets. And those are the ones that we know for a very long time, years and years ago. Then, so you always try that first. And what you ideally want to aim for, it doesn't always work out. You want to aim to be able to see how a patient responds to this medication, either singly or in combination over a 6-month period. And we call that phase 1 of treatment. I think, Doc, phase 1 is a good time for us to take a little break. So we're here with Dr. Dyaanand. He's a consultant rheumatologist. Very importantly, we're going through the diagnosis and the treatment of rheumatoid arthritis. We're very keen for you, our audience at home, people who may be suffering from this condition. Please interact with us. Please send in your messages. Please send in your questions in the final segment of the program. You can send it in from now, and we'll address it in the final segment of the program. Please take advantage of the opportunity of Dr. Dyaanand being here with us. So guys, we're going to take a 1-minute break, and we'll be back in 1 moment.
Controlling diabetes can be challenging, but at Caribbean Dreams, we have it down to a T. Caribbean Dreams Cinnamon Mint with Stevia. Cinnamon increases the body's ability to regulate blood sugar by increasing glucose metabolism. Peppermint adds that pepper flavor, while with Stevia all-natural sweetener, there's 0 calories and 0 carbs. Help keep your diabetes under control. Drink Caribbean Dreams Cinnamon Mint with Stevia. Caribbean Dreams, never stop dreaming.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest.
Welcome to Harvest. We're doing the double again, north and south. This morning we start here in Brazil Village on Bethany Estate with Michael and Jacinta Mill.
You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance.
So Wendy, you're about to show me your bromeliad house.
Yes.
Oh, this is lovely.
This this is what our customers refer to as the mecca for bromeliads.
Explore the many ways to make your harvest right for you.
So our chicken coop is more or less built at a height whereby it's easy for us to go and just remove the wood shavings into our barrow.
Now, you don't plant out your seedlings, you buy the seedlings, right?
Yes, we purchase our seedlings.
Here we are on a not quite monocrop site, but we have rows of tomatoes, rows of sweet peppers, and then you have the Milnes polyculturing.
Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture.
All right, welcome back, guys. We're here with Dr. Dyaanand, consultant rheumatologist. So, Doc, just before we went to the break, we were really trying to hammer down the treatments and the available treatments for the patients out there.
Right.
So we started off with bridging therapy, which is initial treatment, anti-inflammatories, prednisolone. It should help them with the pain. Take them to the second step, which is the disease-modifying agents.
Right.
You listed out a few of them,
Right.
and you can take it from there.
Right. So the disease-modifying agents, I was saying, traditionally,
Yes.
the common ones everybody know would be the four that I call methotrexate,
Yes, methotrexate.
sulfasalazine,
Yes.
hydroxychloroquine,
Yes.
leflunomide, or Arava.
Right, and these have been around for a long time.
And these have been around for
How many years?
Methotrexate has been around for more than 50 years.
Okay.
And similarly, some of the other drugs.
All right.
Arava, out of those four, Arava is probably one of the newer ones. That's the leflunomide.
Okay.
So what we aim to do is we are aiming to start a patient on what we call the core drug. And the core drug should actually be methotrexate.
Right.
So once there is no contraindication to the use of methotrexate,
Right.
meaning that you do your chest x-ray, you do your blood test, it's all
Right.
normal, then
Right.
what you want to do is you want to actually start methotrexate as soon as you could.
Okay.
Methotrexate is a once-a-week drug.
Okay.
So usually you give the patient a fixed time. I usually give them a fixed time. I tell them a Saturday night, take it after
Right.
dinner.
Right.
And then together with the methotrexate, you want to be using folic acid.
Right.
And the folic acid, you could either do it one or two ways. You could do
Yes.
a 1 milligram small dose folic acid on a daily basis,
Yes.
or you could do a 5 milligram 48 hours after the methotrexate.
Right.
You start at the methotrexate at a lower dose.
Yes.
And once you start the methotrexate, you have to check the blood count and the liver, make sure that it is normal, and then you see you review it. Once it's normal, you go up on the dose.
Right.
What you're aiming to do is to optimize the dose of methotrexate to a dose of about the equivalent of 0.3 milligrams per kilogram of the patient's body weight.
Okay.
If you get to that and the patient can tolerate it and there's no side effects and the patient is doing well, you continue.
Right. So Doc, sorry to keep interrupting you, but
that's
I
right.
have to keep relating it back to the audience.
Yeah.
And the audience, one of the key things I find in medicine nowadays, I mean, everybody's concerned, and rightfully so, everybody wants to know about side effects.
Yes.
Now, sometimes when you see the patients, or any other rheumatologist see the patients, and start them on methotrexate or different drugs, they do bounce to the general practice and go, hey, Robin, you start me on this tablet, any problems with it? Is there any problems with these disease-modifying drugs?
So there are concerns just like there would with any of the medications.
Right.
So it is my practice from ever since. I usually, first of all, tell patients that you need to spend a little time in between. You see that bridging period before we start? Do a little bit of research and I will address all the questions.
Exactly.
So the key things for methotrexate is, one is some patients complain of upset feeling with the drug.
Right.
If you are having real problems with upset feeling and you can't tolerate it, we could switch it to intramuscular methotrexate. The second thing is with methotrexate, we need to monitor the blood count because sometimes it could cause a dip in the white cell count.
Right.
Then we need to monitor the liver function because sometimes it could affect the liver.
Right.
So those are the key areas: the upset feeling, the blood count, the liver.
All right.
Now another area that some people
methotrexate is most prescribed disease-modifying drug out
most common, most common throughout the world.
Right. So we acknowledge that it might have some side effects, but the benefits are a huge outweigh the risks.
Right. So,
and in the hands of a skilled professional like yourself, the patient could remain, be rest assured that we are aware of that, we monitor it, and we make sure it does not happen to you.
Right.
And if it happens to you, we know what to do to help you.
Yes.
In conjunction with yourself as a patient, obviously.
And the phrase I always like to tell patients, which is exactly what you said, you weigh the risk against benefit.
Risk against benefit.
And if the risk of taking a drug, as I tell all the patients, is greater than the benefit, then don't take the drug.
Then don't take the drug.
But if the benefit significantly outweighs the risk, well then by all means, you take it, we monitor it closely, and we see how everything works
But
out.
in medicine, you must not let fear of something stop you from getting improvements either.
Right, exactly.
You know, sometimes in medicine, we in general practice, to relate it back to my field, we made fear becomes the guiding principle for a lot of people about how they choose medical treatment. And education is a way to eliminate fear, and having a good relationship with your doctor, like your GP or whoever is treating you, will help you eliminate that and make the right decisions and right choices.
I fully agree.
So, Doc, the disease-modifying drugs, methotrexate, we go on, we give the patients methotrexate, we give them folic acid. What happens next?
Right. So if the methotrexate is working, and within the 6 months period, the patient is doing fine and the symptoms have resolved and you're able to taper off the steroids and the painkillers, then the patient stays on methotrexate for a few years.
Okay.
If, however, by 3 to 4 months you find that this methotrexate, the patient can't tolerate it, there's a side effect, or you're not getting the benefit you want, then you need to start to think about combination therapy.
Okay.
So you would want to add either hydroxychloroquine, sulfasalazine to the treatment. So we could go from monotherapy with methotrexate to double therapy with methotrexate and another drug like hydroxychloroquine or sulfa, or you could go to triple therapy, which is methotrexate, sulfasalazine, hydroxychloroquine.
All right. So, good. So the patients at home, knowing that we have these class of medications, we could go all the way one, and then the doctor has the option of combining them, 2 different ones. So you have lots of treatment options available, and a practitioner have lots of room to move to help treat people with rheumatoid arthritis. I say the same thing to diabetics as well. We have loads of options and loads of room to move before, to help you. Doc, I just want to get a little bit more scientific. Why do they call it disease-modifying drugs? Why do we hold it up like this and go, these are disease-modifying drugs? These are brilliant. How do they work to modify disease? Why is these things so great?
Right. So that's an excellent question. So I like that question because that is actually the convincing point.
Exactly.
Because a lot of patients, they feel good with the steroids. And they feel good with the painkillers. And they say, well, if I've taken prednisolone and I'm feeling good, why can't I not continue prednisolone for the rest of my life?
I think it's a very reasonable question.
And why am I going to take these medications that are going to run the risk of having a little side effect?
Side effect, yes.
Right.
So how do you answer that?
The difference is that prednisolone, painkillers, they make you feel better, but they do not influence the disease process.
Okay.
But methotrexate, the reason why it is called a disease-modifying drug is because it alters the disease process, it brings the disease under control, and it prevents the long-term damage that you get with the joint. So what you don't want, you see a lot of rheumatoid patients with deformed fingers and toes. You do not want that to happen. Prednisolone cannot stop it. Painkillers cannot stop that. But the disease-modifying drugs actually alter the disease process, and they could prevent that.
Right. So the disease-modifying drugs stop the process or slow down the process.
Slows down the process.
And I think that is why 15 to 20 years ago, when I was an intern, the consultant pointed at me and go, if we continue like this, we're going to probably cure or put it in. Because these drugs are fantastic in that they slow down the actual rheumatoid arthritis. And traditionally in Trinidad, and no criticism to anyone, but at the general practice level, we tend to have, in the past, we tend to have this focus only on pain relief for the patient.
And a lot of patients also have that once they feel better, that's what they're concerned with.
That's what they're concerned with. But we have reached a stage in rheumatology where we could slow down the actual disease process and stop people from getting joint deformities. All right? You can continue on there, Doc. Sorry.
So once we get to that stage, we use combination therapy. And let us say, for example, now you try the methotrexate alone, it didn't work alone. You combine it, it didn't work. And you use multiple combinations, 3 drugs, no it work. Then that's one stage of the treatment, and that's the tablets. Then we move to the next stage. Once we have failed with that first stage. And the next stage is about all these wonderful drugs that you see about Humira and Remicade and Enbrel and all of these drugs. So these drugs now fall into a different class. So they are also disease-modifying, but they are called biologic agents.
All right. And how long have these biological agents been out?
More than 20 years.
All right. Cool.
So when I left England in 2002, the biologic agents was something that were now coming into vogue, and we were doing.
And we have that up on the monitor there.
Yes, and we were now getting into vogue in the use of biology. We were being trained how to assess patients for the use of biologics. But over the 20 years, the ones that we started with, which was the Humira, the Remicade, the Enbrel, they've actually added to that group. And now we have other groups. So we have a group of drugs called anti-interleukin-6. Everybody will be familiar with this drug because it's been bantered about with COVID. The Actemra that they want to give everybody IV. Actemra, one of the first licensed Actemra got was for the treatment of rheumatoid arthritis. Now Actemra has other license.
Right.
And then you have what we call anti-B cell drugs. So that there's a drug that we have available here called rituximab or Mabtera.
Right.
That's another biologic agent.
Right.
Then you have an anti-T cell drug, which is not available in Trinidad. It's another biologic agent. So we have a whole host of biologic agents. So what we will do now, we try the oral medications. They don't work. Patients still struggling because the majority of patients will get benefit with the oral agents. So when I say they don't work, we're referring to the people who do not respond to the initial approach to treatment.
Yeah.
So you're separating out you're categorizing the patients now. So these are what we call the failure to respond to the initial treatment. Then we go to the second phase, which is the use of biologic agents.
Yeah.
So we might say, okay, we still keep you.
Yeah.
We do not stop the oral agents. So we do not stop the phase 1 drugs.
Right.
We don't stop the methotrexate, the sulfasalazine, the hydroxychloroquine. We don't do that. We keep that, and we add on a biologic agent.
Right.
And then we watch to see what response you get from the biologic agent.
Right.
If you, for some reason, you couldn't tolerate one biologic agent, then we have options. We could say, okay, you can't tolerate that. We could go to another one if you have tolerance problem, or the reverse might be true. You might be taking the biologic agent, and that may also not be producing the benefit you want from the drug. Then we could actually switch drugs.
Okay.
So we could keep you on the oral agents, and then we could use one biologic agent, and if that fails, we use another biologic agent. So we do have a nice little pathway to go.
Right.
And then there's even a phase 3 where you could start to actually change and combine biologic agents, which would be the more recent things that are going on.
All right. So in terms of drug treatments, right, let's just count them out. How many different options you have? You have about 4 tiers.
Yes.
And you have about how many actual agents available to you here in
so
Trinidad?
in Trinidad, when we first brought the biologic
and there's a
agents,
reason I want to get this out. Yeah.
So when we first brought the biologic agents in, we had initially 1, 2, and then 3. Now we have about 4 anti-TNF drugs alone.
Right.
Then we have the anti-interleukin 6, the Actemra, which is a 5th drug.
Right.
We have Mabtera, which is a 6th drug. So we actually have about at least 6 of the biologic agents that we could use in various combinations.
All right. So one of the reasons I got you to go through it, Doc, I mean, a lot of the patients at home or the people at home might not fully understand what you're saying in terms of the actual names and the combinations. But the reason why we went through it is because sometimes they see people give up hope.
Right.
And in practice, they see people out there, they have arthritis, and they say, well, I have arthritis. And the head shake like this, and then it drop like this, and like if dies it.
Right.
And the only option they have is painkillers. Right. But you're hearing it himself from Dr. Dyaanand here, is that he's a man who was able to pull on a great range of agents and a great range of different classes of medication. So it is no hang-head situation. It is no rheumatoid arthritis is not a situation where you hang your head and say, oh, dies it, or there's different options and it's limited. No. The field of rheumatology has progressed so much that we really should not have people in pain.
No, we
right? So we should be able to treat people with and keep people feeling good and have them doing what they call the activity of daily activities.
Living,
so that's what I really wanted to put out there for the persons. So Doc, let's move on a little bit away from the treatment there. Well, from the agents, the treatment there. The key thing about rheumatoid arthritis as well is that, and I don't mean to answer the question I'm asking as well, is that it's more than just joints.
Yes.
People think that rheumatoid arthritis only affects the joints. How else does rheumatoid arthritis affect a patient?
Right, so one of the biggest things that people should be aware of with rheumatoid arthritis is that it's, as we said earlier on, an autoimmune inflammatory conditions.
Yes.
And all autoimmune inflammatory conditions, as time goes on, it will be proven, it has so for rheumatoid already, increases your risk for heart disease. So if you have, say, 1% chance of having heart disease on the background of you not having rheumatoid, I'm just using this figure to make the point. Then if you have rheumatoid with whatever background condition or no condition you have, your chances of having heart disease increases but to 1.5. So the point I want to make that rheumatoid itself is a risk factor for heart disease. So you know, like how we will know diabetes, hypertension, high cholesterol, and everything
course.
are risk. Rheumatoid arthritis is an independent risk factor for heart disease.
Right.
So apart from getting on top of the joints, you want to get on top of the condition because it will help bring down that risk.
And is it because, like we talk about nowadays about medicine, about inflammatory conditions affecting the whole body?
Right.
So because it's inflammation throughout your whole system.
Right.
So, all right. So other than the cardiac,
right. So the heart disease is one of the big ones I want people to be aware of.
Of course.
And that will actually heighten their awareness of why we should be on top of the disease. The second thing is, and I have a lot of patients, rheumatoid can affect the eyes. So you could get various things going on with the eye. You could get inflammation mostly at the front of the eye, and you could present to your ophthalmologist with various eye problems. Rheumatoid could sometimes affect the lungs, so you could get rheumatoid lung disease. Rheumatoid could actually affect the blood vessels in the body, so you could get something called rheumatoid vasculitis. So we actually have a couple of patients who have rheumatoid arthritis, and they will present with this inflammation of the blood vessel, which actually compromises the blood supply, especially to the fingers or the toes, and you could get the toes and the fingers becoming gangrenous.
Wow.
And that could be as a result.
They could lose a limb.
And they could lose the toes.
Digits,
so at present, I have at least 2 people who actually have inflammation of the toes. They have led to gangrene. So we're in the process of walking them through the process until the gangrene sorts of dry gangrene and and auto amputates for itself. So that's one of the other big and I've seen it on multiple occasions.
And I think you get skin problems with rheumatoid arthritis.
So you could get some skin problems. A lot of the skin issues we see with rheumatoid really has to do with a lot of the rheumatoid nodules. For example, you get little lumps behind the elbows or so. And those, and there are other things that could happen, but those are the key ones we see. I actually have one patient with rheumatoid who had inflammation of his aorta, which is a big vessel, as you know, closed coming out of the heart. You can get inflammation in those vessels.
All right. Doc, I think we have a WhatsApp coming in that they want us to have a look at. Andreas, put it in, and then we take the break. Thank you for such an informative program on the topic of rheumatology. And Ari, these types of programs are much needed at this time. What is the recommended diet for rheumatoid arthritis and other patients with autoimmune conditions? Swami Brahma Dev, India. Okay. Wow. So, Doc, that's somebody out of India. They're asking us a question.
So thank you very much, Swamiji, for that question. So I think that the non-medical aspect of treatment, the medical aspect, which we talked about a lot, I think the non-medical aspect, in my opinion, is equally as important. And I like to split the non-medical aspect into lifestyle, and lifestyle includes like diet, supplements, and regular things like exercise. So if we go to the diet, what you really want for rheumatoid arthritis and other inflammatory conditions is you want anti-inflammatory type food. So you want to avoid the things that are well known to be pro-inflammatory, like refined sugars, white flour, red meat, those sorts of things. And there's a list you could get. So you want anti-inflammatory foods. And the key ones I tell patients is to try to cut back on the refined sugars and the white flour and so on. Then what you want as supplements is you want anti-inflammatory supplements. So anti-inflammatory supplement comes in the most common form, omega-3. And you don't have to buy expensive omega-3 if you can't afford it. Simple things like cod liver oil you could use, and you get omega-3 from it. You have for people who don't use meat or fish or so, you could use vegetarian and things. You could use like flaxseed and you can get omega-3 from it. So omega-3 is actually useful, and there is a role.
So you prescribe omega-3 to your patients?
We do. And actually, following the last American College of Rheumatology meeting,
it's a part of the guidelines?
There's actually recommendations now. So they haven't made the guidelines as yet, but there's actually official work that has done that has shown that omega-3 is helpful for people with various types of autoimmune conditions.
I said flaxseed oil.
Flaxseed has omega-3. So it's a plant-based omega.
And then the avoidance of inflammatory foods, so like refined sugars and refined
sugars, the white flour, red meat.
Is there anything other natural food? Because I think this is what the viewer was getting at. Is there any other food that we could include in our diet that might help us with our inflammatory conditions?
So I would like to think of as a general term, you want to probably look at what they typically refer to as a Mediterranean type diet. So I think that with a lot of fruits, a lot of vegetables. If you eat meat, probably fish. and especially fish that is high in omega-3, just for an example, like salmon, fresh tuna, fresh sardine, not eating sardine, like that. Those things are good.
All right.
So they should be helpful.
All right. So, Doc, we're just going to take the next break now.
Sure.
So we're going to take a little break. And when we come back, we're going to answer some more of your questions. Please send in your questions. Take advantage of the fact that Dr. Dyaanand is in with us tonight. And he's a consultant rheumatologist with his Center of Excellence in Rheumatology located at Dumfries Road in La Romaine. So we'll see you in 1 second.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
You're watching ACTN The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're talking rheumatoid arthritis. We're talking here with Dr. Dyaanand. And Giles, I think we have another question coming through. If you could put it up, your WhatsApp. No? All right. Doc, I'm on methotrexate. I'm on methotrexate more than 15 years. That's fine. Thanks, Giles. Do I have to stop medication to take the vaccine? Would it work since immune suppressant prevents the cells from fighting the virus and building antibodies? I cannot stop medication. It causes severe pains. Doc, you have the gist of that question, right?
Yeah, we have
it's a very good question.
Yeah, very good question.
It's a very relevant question.
And very relevant to our time.
Yeah.
And the answer to that question
it's a question I wanted to ask.
Yeah, it's very simple.
Yeah.
One is, the answer is you do not have to stop methotrexate in order to take the vaccine.
This is the COVID-19 vaccine.
The COVID-19 vaccine. So there are some guidelines that has come out from various international bodies. The American College of Rheumatology probably has the latest one. And the guideline is just you take the vaccine and you stay off methotrexate.
You could put it back up there, Giles, please. Sorry,
so you take your vaccine and you leave off the methotrexate just for one dose after the vaccine, but then you go right back on your methotrexate. When you get your second shot, you do the same thing. When you get the booster, you do the same thing.
All right, about that part there, would it work since immune suppressant medication prevents the cells from fighting the virus and building antibodies? So methotrexate is an immune suppressant drug?
Yes, it is, yeah.
Right.
So, and it doesn't negate the effect of the vaccine at all.
Right. In fact, I think, Doc, we would recommend people on the immune suppressant to get, that's the first line.
So we definitely recommend all patients with autoimmune conditions and patients who want autoimmune drugs. Those are the patients especially you want to target.
Exactly, exactly, to prevent it. Yeah, Giles, you have another question? Good question, caller, viewer. Good night. Send in a question for Dr. Dyaanand. Question. Are there any natural or complementary treatments that are available for persons with rheumatoid arthritis?
So that would relate, yes.
You touched there
yes,
a little bit before the break, but you could just
yes, so just to remind you that yes, there are things like the omega-3s, like the turmeric anti-inflammatory products that you could use, and those are the ones that we use mostly, and we do get some benefit, but I will hasten to add that I would suggest that we use them, but we use them in combination with the traditional medicines that we do. So I don't necessarily say that it's an alternative.
Okay,
so I say it's an adjunct.
Adjunct, and we are good. So you're using your regular medications,
yes,
but we certainly do see the role of those complementary medicines, as the viewers getting at, and you lifted them out there about twice already. Giles, any other messages? Is chronic fatigue syndrome a rheumatoid or rheumatoid autoimmune condition?
So chronic fatigue syndrome belongs to the realm of rheumatology, but it's not really a rheumatoid condition. It's not an autoimmune condition, but it is managed by rheumatologists, and it falls in that field. They also, a lot of people who do neurology see patients with chronic fatigue syndromes, but it's not really autoimmune per se.
Okay. Okay. Right. Does polymyalgia rheumatica fall
yes, polymyalgia rheumatica definitely falls under rheumatoid, and it's a very interesting one to ask, because polymyalgia rheumatica could actually be polymyalgia rheumatica on its own, which is a rheumatologic condition which requires treatment, or you could actually get, because we're talking about rheumatoid arthritis, you could get something called polymyalgic onset of rheumatoid arthritis.
Right.
So you actually get a patient presented and looking like they have polymyalgia rheumatica, but they slowly evolve to rheumatoid.
Rheumatoid arthritis. Yep. All right. So this self-vigilance is important.
Yes, it is.
All right. Just sorry about that. You can back up the question. Good night, Dr. Dyaanand. Excellent talk. Very informative. Can you give any advice on the COVID-19 vaccine among the rheumatology patients?
So
you could give back.
So I would strongly recommend, to start with, there is, to put it to make the key points out of it, first of all, there's no contraindication to taking the vaccine, right? If you have a rheumatologic condition, or if you have if you're on immunosuppressive drug, that's the first thing to know. The second thing is, because rheumatologic patients, for all, just rheumatoid arthritis, are patients who have chronic diseases, they would be at a higher risk if they do get COVID of having more severe disease. So those patients in particular are actually encouraged to actually take the vaccine.
Okay.
And there are guidelines, we touched on it a little bit. If you're on the immunosuppressant, certain drugs, you need to just leave it off for 1 week after the vaccine. And if you're on high doses of steroids, you need to discuss that with the physician, because if the dose is above a particular, above 20 milligrams or so, you probably don't want to push for the vaccine at that time. You want to bring the dose down a little bit, but you still give the vaccine. So if you're on a small dose, you could just go straight ahead and take it.
All right. Doc, let's fill in the pulse of the questions that are coming in there, right? There's obviously a concern about immunosuppressant drugs.
Yes.
How would you advise a patient who is on immunosuppressant drugs, I know you talk about the vaccine, to know if they're running into a problem? What problems they have to look out for if you're on immunosuppressant drugs, and how would they know? You get my drift for the question I'm asking?
In terms of side effects from the drug, or with the infection?
Exactly.
With the infection. So usually, well, if you actually get...
because they need to hear that.
Yes, so if you do get the infection, one of the biggest problems you have is, in our setting is, and worldwide, we see people who have a lot of respiratory problems.
Right.
So if you do develop significant respiratory problems, then, and you are on immunosuppressant, it might be a good idea for the period in time when you are symptomatic to actually withhold it, meaning cough, shortness of breath, problems like that.
And even before you have respiratory problems, I think people need to, patients need to be conscious that once they're on immunosuppressant drugs, if they start getting any sore throat, any pain in throat, go and see a doctor early enough.
Early enough. So that's the key thing. The key thing is you want to be assessed early on.
Exactly.
In whatever form, you need to be assessed.
All right. All right. So, Doc, let's push through again. So, Giles apparently put up a next question there. Dr. Dyaanand, what tests should someone do in their medical checkup/blood test to see if they are prone to RA instead of waiting for physical deformities? Also, is RA hereditary?
Right, so we mentioned about the RA being hereditary. Yes, it does run in family. And interestingly enough, I don't recommend doing routine immune tests like a rheumatoid factor or an anti-CCP, because they might have a predictive value, so they might tell you that, look, you might be developing rheumatoid, but on the flip side of it, it doesn't necessarily mean if your rheumatoid factor turns out to be positive that you are going to develop rheumatoid, because you could have a rheumatoid factor being positive in a normal person, you could have rheumatoid factor being positive in other conditions. So to do the autoimmune test as a screening test by way of a yearly check is not recommended. There's no official guideline that says it. The flip side of it is if you have joint symptoms, then you want to know early on, very early on, that whether this is rheumatoid or not rheumatoid, you want to do the immunology test. And how it relates also, and it kind of ties up to the hereditary question, is if you have rheumatoid arthritis and you have a sibling, a brother, a sister, or even a parent or children, and they actually develop joint symptoms early, you know that your first degree relatives are at a higher risk of having rheumatoid. So you want to make sure you get them assessed early, and you want to have that test done, but you don't need to do the test routinely beforehand.
All right. Right, so your relative has rheumatoid arthritis, you get in pains, get into the doctor's office and start assessing early on. Because it
might be relevant.
It might be relevant.
Yes.
Go, don't make sheep.
Yeah. Yes.
Next question, Giles. Hi, good night. I would just like to understand what is the need for an X-ray as one of the methods to diagnose rheumatoid, besides blood tests.
Right, so
please and thank you.
Right, so the X-ray doesn't really diagnose rheumatoid per se. The X-ray, most of the times when we do it as a pre-screening, and the pre-screening actually is for the purpose of making sure that there is no underlying lung problem or lung issues that we need to know of.
All right, Chaz, any other questions? Yeah, you can put it up. Are there support groups in Trinidad and Tobago for RA patients? Excellent question.
Right. So, as far as I'm aware, we don't have RA-specific support groups. There is a society for lupus, for example, but not that I know of specifically for RA. So that's probably something that we could do a lot of work on.
That's a good idea.
Yes.
That's a good idea, Doc.
Yes. So it's a thought that we have had for a long time. But
let's put it together and make it happen.
We need to put it together and make it happen.
Next question there, Giles. How does a person with chronic fatigue syndrome seek treatment? What treatments are there for this condition?
Right, so if somebody suspects that they might have chronic fatigue syndrome, they need to be assessed clinically first, because you want to make sure that it is chronic fatigue syndrome and not necessarily something else.
Exactly, so because a lot of conditions present with fatigue.
With fatigue. So the symptoms of chronic fatigue syndrome are usually non-specific. So you really want to see your doctor, your GP, you get assessed for all the basic routine things. Then the next step is if your symptoms persist, your primary care doctor who assesses you first will refer you on to like a neurologist or a rheumatologist just to make sure there's nothing specific in those areas. And then if all of that is normal and you don't have any specific condition, everything comes back negative, there's nothing specific to treat in terms of medication, something like chronic fatigue syndrome, a lot of it is what we like to call conservative management, but not conservative management from the point of view of doing nothing. But you really need to understand your disease, you need to get into physical activity, you want physical fitness, you want to increase your cardiovascular conditioning. That forms the basis of not only chronic fatigue, but a lot of the other autoimmune conditions too.
Good point, Doc. Good point. Charles, any other questions? Good night, doctor. Do you have any recommendations for myeloma?
So myeloma is a little bit outside of the rheumatology.
That's not really rheumatology.
Yeah, that's really hematology.
You have any?
So for myeloma, yes, I have a big recommendation. If you have myeloma, you should be seeing a hematologist. And you should have it assessed properly.
Yes. So viewer, myeloma needs to be seen by the hematologist.
Yes.
And just basically similar to any other patients, you need to get in there and you need to have the doctor work with you to get through your condition, which is not really rheumatological. Giles, any other questions? Where can I find resources to help me learn more about living with the disease?
Right. So some of
Doc, you have any websites you recommend for our patients?
So a lot of the international places like Johns Hopkins, the American College for Rheumatology, European League Against Rheumatology. League Against Rheumatism.
European League Against Rheumatism.
It's called EULA.
Okay.
And then you have the American College for Rheumatology. Their website have a lot of patient information on it. So they have patient information on the conditions. They have patient reading information, leaflets on the medication. So and those are good official sites like the American College for Rheumatology that you could feel comfortable that you go, whatever info you get from it, you know that, look, you have something solid to work with.
Definitely, I think we need to set up that patient support group for rheumatoid arthritis. Again, if you know that people need education more than just this program. Giles, any other questions for Dr. Dyaanand? Good night. Does methotrexate and steroids affect your menstrual cycle? And if so, what should be done? Thank you.
Right, so it could, methotrexate in particular, you could actually get some bleeding with it. So some people, not much, who take methotrexate, they have spotting when they use methotrexate, and it might be an indication to stop the drug. But if you do develop any trouble with menstruation, we usually like you to see the gynecologist first, because you want to make sure that it might be drug related. May or may not be drug related, but there isn't something else that is going on.
Right.
And steroids could also, as you know, steroid upsets most things. It could upset the menstruation, but not in a permanent long term.
Of course not. When you taper down the dosages, things go back to normal.
They go back to normal.
Charles, just give me a little feedback. Any other questions there? Right. Is there any diagnostic test to determine if someone has RA? And if so, what's the name of the test? Ganesh.
So we mentioned that earlier on, specifically for RA, it's the rheumatoid factor and anti-CCP, specific. Right. There are other tests that have to be done, but rheumatoid factor.
How about an ESR, Doc?
So the ESR is an inflammatory test. So the reason why I didn't answer it and said it's
too non-specific.
It is too non-specific, but it is important. Yeah. So I will do ESR on every single patient.
All right.
But it just tells you that you have inflammation.
Yeah. But it's a good start for someone in the community like us.
Yeah, so somebody has joint pain and you want to do it in the simplest way, do an ESR.
Exactly.
And if the ESR is very high, it tells you that the joint pain is because of inflammation.
Again.
So it's a good place to start.
All right, Giles? What is the prognosis? Good question. For rheumatoid arthritis.
So at the current time, the prognosis for rheumatoid arthritis should be excellent because we have many treatment options. There is a lot of things that we know about lifestyle. There is a lot of things that we know about exercise and physiotherapy and keeping generally fit. There's a lot of things that we know about reducing the risk of cardiovascular condition. So I think the prognosis should be very good, the long-term outcome, but you have to be compliant. You have to seek care early. You have to be compliant with the medication.
And you can't give up hope.
Cannot give up hope.
And if you're hitting a little closed door on your treatment and you're getting pain, you can't just give up hope. You have to go back to the doctor and we'll open our next door and we can keep going again.
And keep going, definitely.
Doc, we have about 1 more minute in the program. Sure. We've come to the end.
Yes.
There's obviously been a lot of interest in this program. There's a lot of interest in the support in support for rheumatology, for rheumatology patients. What final bit of advice you would have for our patients out there? If one last message that if they forget everything, they'll take home with them. Somebody out there, joint pain, suffering, family member who has probably had rheumatoid arthritis. What piece of advice would you give to those patients? And you probably watch that camera and give them.
So the advice that I would actually give someone in a situation like that is you need to seek medical attention early on. A lot of people, from my experience, they actually are very satisfied with staying home, trying their own remedy, a little painkiller, talk to the neighbor. I think that the key thing to do is get out there, see a general practitioner, see a primary care physician in the local health center if you cannot afford to go to a general practitioner, and get tested. That's the key thing, I think.
All right, good advice there, Doc. So guys, it's been a very good discussion. I'd just like to thank Dr. Dyaanand again. Doc, it was engaging. You gave the information in a very fluid, easy to understand way. You gave the viewers hope, and you certainly answered their questions. And I thank you for that.
Well, I'm very happy to be here, and I'm very happy to provide the information.
Okay, Doc.
Thank you very much for inviting me.
You're very welcome. You're very welcome. And we will invite you back on again.
I will be looking forward to it.
Thanks. So guys, as well, thank Dr. Dyaanand again, and thank you at home for sending in your messages. Thanks to those who tuned in tonight. Thank you very much for your support. We'll see you again next week. Have a pleasant evening, everyone. Take care. God bless. Keep safe. We'll see you next week. Thank you.